Inside the human chest, there is a battlefield most people never think about. Not the lungs themselves, but the narrow pleural space that hugs them. Here, bacteria can stage a siege, trapping the lung in a suffocating prison of pus. This is Empyema thoracis, and today we go to war with it. Empyema thoracis means pus in the pleural space, an advanced, infected form of pleural effusion. It is usually a complication of pneumonia, but can also follow chest surgery, trauma, or even esophageal rupture. In children, Streptococcus pneumonia and Staphylococcus aureus are the main culprits. In adults, anaerobes, gram-negative bacteria like Klebsiella and Staphylococcus aureus are common enemies. It begins innocently enough, a pneumonia smolders in the lung, but sometimes the infection breaches the pleura. Inflammation floods the pleural space with fluid. Fibrin forms webs that trap bacteria in pockets, called loculations. Over days to weeks, a fibrous peel can encase the lung, locking it in a state of collapse. Clinically, we describe 3 stages: the exudative phase, thin infected fluid, free-flowing; the fibrinopurulent phase, thicker pus with fibrin and loculations; and the organizing phase, a fibrous peel trapping the lung, also known as the trapped lung stage. The warning signs can be subtle or dramatic: persistent fever despite antibiotics, cough, chest pain, and breathlessness, night sweats. In children, refusal to feed, abdominal pain, or unusual tiredness. On examination, you may notice reduced chest movement, a stony, dull percussion note, diminished breath sounds, or sometimes a bronchial breathing quality over the affected area. Diagnosis begins with a chest X-ray, which may show opacification, a meniscus sign, or complete whiteout of one lung. Ultrasound helps identify septations and guide safe drainage. In complex or recurrent cases, CT scans map the extent and guide surgery. But the ultimate confirmation is a pleural tap. When thick, foul-smelling pus fills the syringe, the diagnosis is clear. Treatment must be decisive and urgent. First, antibiotics. Broad-spectrum intravenous therapy started immediately, then tailored to culture results. Second, drainage, usually with an ultrasound-guided chest tube, placed in the correct position and size. Third, breaking down loculations, with intrapleural fibrinolytics such as TPA and DNase. And finally, surgical backup when needed. Video-assisted thoracoscopic surgery for debridement and drainage, or open decortication for organized empyema with a thick fibrous peel. If left untreated, empyema can lead to serious complications: sepsis, bronchopleural fistula, chronic lung restriction, or even death. In children, delayed drainage can permanently impair lung growth and function. Prevention comes down to early, effective pneumonia treatment. Remember, if a patient's fever persists beyond 5 to 7 days despite antibiotics, think empyema. Do not wait for the pus to thicken, the lung to shrink, or the patient to weaken. Empyema thoracis is a battle that can be won, but only if recognized early and fought decisively. In medicine, as in war, timing is everything.